Hello everyone. Can you all hear me properly? Hi guys. Can you all hear me? Why everybody is in silence? Can you all switch on your mics and then let me know whether can you all hear me or is it not clear or anything?
Can hear, sir.
Can hear? Great. Okay. Is it like properly clear?
Yeah, it's clear.
Great. Okay. So let me share my screen. Hmm. Can you all see the screen?
Yes.
Good. All right. So some of you may know me, or most of you might not know about me. I'm Dr. Johan. I'm one of the gynecologists in the country. So I'm currently working in Rikit Lakaskada Hospital. So I enrolled to this ERPM teaching like few months ago. So basically, the current students who are doing OSCEs, like they have done set of sessions, MCQ sessions, and OSCEs with me. And actually, most of them like gave me good feedbacks. And I'm a MBBS examiner as well as a ERPM. So you can, we'll move forward. Like I think you have your the MCQ and SBS first, and getting through that, you have your OSCE stations. Am I right?
Yes.
Yeah. So, guys, please now this is like that. Like this, if this is going to be kind of monotonous by me talking only, this would not work much. So always we'll keep interaction, and then I'm so flexible, and we all have to understand that this is a barrier exam. So being a barrier exam, you have to push yourself. To push yourself, you have to break all the nets in front of you. So basically, don't get panic, don't get disheartened. We all can make mistakes. When I was a student, I made mistakes. Even now, being a consultant, I can have, we none of us are perfect. So understand that. Never hesitate. Please don't be shy. I'm very flexible and a convenient person. You're completely all right to ask me questions. Otherwise, there is no point. At the end of this session or at the end of the few sessions ahead, you should feel you're better than today. That's my idea of doing this. Now, I really appreciate all of if you all can switch on your cameras, please, because this let's do this as a as interaction thing and as like a proper class. Even though we are doing this as thank you, Imesh. So let's see. I cannot see everyone. Okay. So please switch on your camera so we can do like a proper interactive session. I'm not going to like basically question you or push you through, because this is a introductory MCQ and SB session. So my idea of doing this now, you guys, if you're going to enroll this and get this session done, you guys are going to going to pay for this. So you spend money, so there should be a better outcome, right? And my idea of doing this, like this particular session is today I'm doing the interaction where I selected a couple of topics. One is from obstetrics, that is labor, which is the commonest, most topic, and out of your SBAs or MCQs all together, 1/3 of them were related to abnormal and normal labor. Surely it is like that, because that is something that as a house officer you cannot lose, right? So all these, now most important thing about this exam, ERPM exam or final MBBS, is the consultants are looking forward to find a good house officer. The meaning of good is to find out a safe house officer. If you are practicing safe, if you are understanding knowledge and your like what do you call this attitude is basically safe, you will be eligible to become a house officer for any consultant. So the first barrier that you get is MCQ and SBAs. So none of us being consultants want maternal deaths or neonatal deaths or infant like fetal deaths. Because of that, majority of the questions will be asked through obstetrics, and in obstetrics it is coming through labor, right? And then you can have gynecological conditions. So I have selected 2 topics, but this is not all. Only 7 questions from labor and few questions from gynae oncology, like cancer related, which is again common, which is again life threatening. So you have to know, right? So that's my basic introduction for you. And then after this free session, I'm starting the proper sessions of 50 questions per day or maybe 25 questions per day, probably weekly or a couple of times a week, based on the feasibility for you all and for me, right? And then I'm going to do at least like 300 questions during this proper like sessions ahead, which is absolutely good enough to get through the exam. Believe me, the reason I'm telling this is you don't have to do like 5,000 questions. You just have to understand how questions like, how am I going to evaluate this question? How am I going to get the information what the examiner is looking for? So as a student, when you read the question, never ever think that it is as a question. You think it, okay, what is the examiner's intention of asking this? Each and every question. For like first few days, you'll get more time because you have to think why this question is asking, why this stem, why they're asking whether this is correct or wrong. So likewise, when you start thinking with time, that time gap will be shortened and shortened, and then you'll realize at some point, okay, this is the reason that he's asking this question. This is the answer. This is the reason this stem is up there. So this is the answer. So practice yourself. Keep practicing, but that doesn't mean that numbers. There can be a student who has practiced like 200 questions, performing well, than a person who did 5,000 questions. It's not the number, it's the way you think about it and way you analyze it and do kind of like the application of your knowledge. Okay, so that's the basic information and the statements that I want to make before starting this. Right. So far, am I clear to you all? Right? Can everyone understand? Is it all right? Yeah. Okay. All right. So right. So let's start the thing. So this is one of the very important information, or the statement made by one of my consultants when I was a medical student like you. Even for like local graduates, when I'm doing classes for them in Peradeniya, Colombo, wherever it is, I always tell this. He told me, you try to jump over this hurdle, right? Then you'll start seeing a different world. That's absolutely true. You will see different people, you will meet different caliber of people, people with different set of mentalities, like, high standard of brains. And then you talk good stuff, you thrive. Believe me, that's number one. Number two, believe in yourself. I still have, like, I still see some of you have not switched on your camps. That's all right. But I really prefer, open up yourself, show yourself, feel this as a kind of a group class. So that will definitely help you, because you are interacting instead of like no show, right? And then work hard. You have to work hard. People say, like, work smart, not hard. No, you work hard, work smart. Apply both. Give your best version to yourself. Next few weeks, I'll help you to get through this exam. Promise you, because my feedbacks from the previous group was really good. They're happy about the new knowledge. They're happy about the way they faced the OSCE. So I'm really like self-satisfied with that. So you have to trust yourself, believe yourself, and don't ever what do you call this, cheat yourself. Because when you start working, when you get tired, you feel like, okay, I'll do this question, I'll do this two question quickly. You read Wikipedia, you go AI, find the question answers, you get the answers. That's not this work. If you get to practice like that, because none of the questions will be repeated. None of the questions will be repeated. The new set of, because we are making questions for the final exams, we create a new pool. You get questions from a new pool. Theory and everything will be the same, but the question comes in different ways. I'll show you why today, and then when we go through one by one. So work hard, work smart, don't cheat yourself, open up yourself, continuously question yourself as well as me. You are completely free to question me, because you guys pay. I have to do a proper job for that. Okay? All right. So let's start from the first question. These set of questions are from labor, right? I want you all to read the question first and give your answers if you can. Then I'll tell you whether they are correct, wrong, why they are wrong, and why they are correct, and how they comes in. Okay. You know the labor process, right? You know what happens in the labor process, So usually the labor process, you get the engagement of the head, descent of the head, flexion, right? Internal rotation, extension, restitution. Those are the steps of labor, right? Now, don't get upset. I know some of you may not be, so familiar with this one, because you are just starting your MCQs now. So if you don't know the process of labor, mechanism of labor, go ahead. After this session, get the book, get your notes, read about it, absorb it, and then try the question again. Okay? Now, the progress of labor is determined by assessment of cervical dilatation, assessment of descent of the head, measurement of the amount of caput formation, measurement of the frequency of contractions, performing an amniotomy, right? So, okay, the progress of labor. What do you mean by progress of labor? Whether the labor is progressing or not. Is it? බබා හම්බෙන progress එක වෙනවද නැද්ද? ඒකනේ අහන්නේ. How can you assess the progress? Can you assess it by cervical dilatation? Yes or no? If the labor is progressing, should the cervix get dilated or not? Yes. Oh no. සමහර අර ගමරාල ඉන්නේ තට්ටුවක් දැම්මම yes or no? What is it? Is it yes or no? It should dilate, right? If it's dilating, it's progressing. දැන් මේක තල්ලු වෙනකොට අරෙන්න බෑ. If the head is pushing the cervix should dilate, right? Okay. So that's true. What about the descent of the head? When you assess, you know that when there are like times that you do vaginal examinations in labor, you know, we maintain a thing called partogram. Partogram. We maintain partogram. So most likely, like in uncomplicated labor, we usually do four hourly vaginal examinations. When we do, we check whether cervix is getting dilated. And then descent. Descent can head whether the head is descending, right? Is it a determination? Whether is it determining the labor progress? Does it? Yes. Right? Agree? What about the measurement of the caput formation? Measurement of the caput formation. You know what caput is, right? Do you? When the contractions are there, when the head is descending, the soft tissue of the fetal head gets swollen, right? That is a natural process. But if the caput is extensive, it's extensively growing, that indicates, if it's extensively growing, that indicates what? That indicates head is not descending, the soft tissue is swelling. Okay? Understand? So that is obstruction. That is not the progress of labor. That is obstruction. Okay? Understand? And then measurement of the frequency of contraction. Does it determine the progress of labor? Measurement of the frequency of contraction. Is it true or false? False. Yes. Contractions should be there for delivery, for the labor, for descent of the head. But contractions alone would not do much, because if the pelvis is inadequate, especially in primaries, contractions will happen. Multis, contractions will happen, but the head will not descend. That's why they form caput. That's why they obstruct. That's why they cause significant molding, right? Contractions is not an indication to determine the labor is progressing, but contraction is something that you need to progress the labor. ඔන්න ඕක තමයි ඔය වගේ questions තමයි හරිම tricky. They are tricky questions because now frequency of contractions දැක්ක ගමන් අපිට හිතෙනවා yes, contractions are necessary and mandatory to progress the labor. But question is not asking that. Question is asking the progress of labor is determined by. You cannot determine the progress based on contractions. Do you understand? Contractions can be there, labor may not progress. But contractions are mandatory for the labor. Got it? Right. So there's a tricky state. වචන හරඹයකුත් තියෙනවා මේක ඇතුලේ. That's like, you know, jump like a gambling, right? Kind of words, right? Performing amniotomy. Why we perform amniotomy? We perform amniotomy when labor is not progressing, we perform. That is to see the lico and also to stimulate more with release of prostaglandins to progress. Api spontaneous labor, we allow them to progress without amniotomy. But halfway through, they stop. Or they are slow. We call it primary dysfunctional labor. In that case, we in that case we have to you know, break the waters. But that doesn't mean, so the idea of breaking waters is to increase the progress. To increase the progress. But the progress of labor is not determined by amniotomy. Do you understand? Now, all these questions, this time the questions that I have introduced to you, all these 12 questions that I'm going to discuss today are kind of not difficult, like, not difficult questions. Samanin easy questions. The reason is this is an interactive thing, and then you have to come back to the track. When you come back to the track shouldn't be graveled. It should be smooth, right? And then one by one, when we are doing in future, we'll get back to difficult ones. Okay? You all can understand me, right? Do you? Am I clear to you? So far, how do you feel about the question? Is it good or bad? Each and every stem, stem I think now dilatation is mandatory, descent is mandatory. So those things determines examination. You tell your boss, okay, sir, it was 3 centimeters 4 hours ago, now 7 centimeters. It was at station -2, now at 0. So being a consultant, I know that, okay, this labor is progressing. Do you understand? Rest will not tell anything. If you tell, so there's a caput, then my understanding, okay, now this can be obstructed. It doesn't tell progress. Then sir, adequate contractions are there. Then I know in my heart, there can be adequate contractions, but certain labors will not happen only with contractions. Then you said, I did amniotomy. You did amniotomy because labor is not progressing. Understand? Or there may be fetal distress. So you need to see the color of LICO. When there's fetal distress in the CTG, you do amniotomy. The reason is you want to see whether there is meconium or whether there is blood stain LICO. What can cause blood stain LICO in labor? Abruption के लिए कहते हैं abruptio placentae. So placenta can separate before delivery. Right? බල ඉන ටීවී එකේ ප්ලග් එක ගැලෙවුවා වගේ. It goes off. Do you understand? The baby is receiving everything to the placenta. In abruption, if you take it off, finish. So do you want to see whether there's early abruption happening? So you open up the LICO, you do the amniotomy. Amniotomy කියන දන්නවනේ? ARM කියන්නේ artificial rupture of membranes. Right? You break it, you see it. Okay? Are we good? Understand? දැන් වා බලන්න ඕනේ examine කොහොමද හිතන්නේ කියලා. Right? Progress of labor determined by, දැන් මම කිව්වේ, you put your legs into a consultant shoes and think, okay, from my house officer, what do I need to know? I need to know the progress of that patient who's in the labor room. So what I need to know is only the dilatation and descent. The rest, if she's or he's telling, those are features of obstruction, maybe non-progressing, so we can have to do a amniotomy. Clear? දැන් හිතනද ඒ විදිහට හිතන්න පුරුදු වෙන්න. ඒක කරාකින් වෙන්නේ නැහැ. That won't happen overnight. When you continue practicing that will happen. So this is logical thinking, not by heart the theory. So if you do 100 of questions like this, still the 101 will be different. තේරෙනවද? ඒක නිසා හැමතිස්සෙම question එක අරගෙන දැන් මේ වගේ වෙලා these days you take time. That's all right, because your exam is like few months ahead, so you have time. So don't lose that opportunity, right? So we'll move to the next question. Active management of the third stage of labor includes. Now this is active management of the third stage කියන එක තමයි ලෝකේ හොයාගෙන තියෙන හොඳම හොයා ගැනීම to prevent PPH. This is the only way the world has, developed to prevent PPH. So each and every house officer should know active management of the third stage. What are the components of active management of the third stage? Make a theory, but very practical. Because maybe at some point, you are the one who have to do this. Most of the time, this is done by midwives, right? So being a house officer, you have to have a superior knowledge than them. Am I correct? Right? Because you have to teach them, you have to guide them. You are the first contact. House office, midwife, doctor, placenta, or house officer, first day. You have to do something about it. Right? So, what are the active management of the third stage? Includes application of the control contraction. Sorry. Only if the uterus is contracted. True or false? True or false? Just true or false? True, false, true. What is that? Application of the control contraction. Have you heard about control contraction? Yeah. You apply traction to the cord while holding the uterus. We'll do this when it comes to OSCEs and further MCQs. What do you think? Application of control contraction only if the uterus is contracted. If the uterus is contracted, you apply the cord traction. Is it true or false? It's true. Mama here, come on. First session. It's true. You have to open up yourselves, right? Okay, it's true. Why is it true? You have to apply control contraction. If the uterus is not contracted, if you apply traction, what will happen? Can anyone tell one answer? Contracted la nathikota, if you apply contraction, what will happen? Can someone tell me? A quick answer.
Uterine inversion.
Exactly. Very good. Ramidu, right? Good job, Matt. Uterine inversion. Uterus contracted apply. And you have to stabilize the fundus. You stabilize the fundus and apply control contraction. Okay? All right. Uterine massage during control contraction. Right or wrong? Right or wrong? You don't massage the uterus. You massage the uterus. What is the third stage, by the way? Third stage is delivery from the delivery of the membranes and placenta after delivery of the fetus. Harine? What is the first stage of labor? Up to the fully dilatation of the cervix. Right? What is the second stage? Fully dilatation to delivery of the fetus. Third stage is delivery of the membranes and placenta. So third stage, you don't massage. Third stage, you deliver the placenta and then you massage. Massage to contract the uterus. Right? So that's wrong. Intravenous injection of 5 units of oxytocin after delivery of the placenta. True or false? මේ වගේ ඒවා මේක tricky. Then now this question මේක අපි හරිය සරලව හිතුවට ගොඩක් කට්ටිය මේකට වැරදි ගහනවා. වැරදි නෙමෙයි, like වැරදි උත්තරේ ගහනවා. They go wrong. What is the reason? You read only the first few things. Intravenous injection of 5 units oxytocin. True. හරිනේ? Intravenous injection of 5 units oxytocin is true. But it is not delivery after delivery of the placenta. Third stage is over. Do you get it? Are we clear? So that's wrong. And then you have a correct one next. Intravenous injection of 5 units oxytocin when the delivery of the anterior shoulder of the fetus. When do you give the third stage? When you give is the 5 minutes bolus when the fetal anterior shoulder is delivered. But ඊට පස්සේ uterus එක contract වෙන්න පුළුවන් ඕන speed එකකින් because we can deliver the baby. When you deliver the anterior shoulder of the baby, that indicates there is no shoulder distortion. Rest will come out. Okay? And then waiting for 20 minutes before applying control contraction. True or false? True or false? That's false. Active third stage is immediate following birth, immediate application of the traction to the cord when the uterus is contracted. Okay? Control cord traction can control traction I control karanno. Why you do control cord traction? Why is need? Why you call it control? That's Ramidu's answer. You don't want to have a uterine inversion. Number two, you don't want to avulse the cord. Cord දෙක කඩනොත් බඩුම තමයි. ඊට අත දාලා ගන්න බෑ. Placenta. So you gradually you keep the control and apply the traction, right? So answers are application of the control cord when the uterus is contracted, intravenous injection of the 5 units oxytocin, then the delivery of the anterior shoulder. So A and D are correct, rest are false. Make it highlight කරන fact එක තමයි you can have question never ever answer without reading the entire stem. Intravenous injection දැක්ක ගමන් ගහන්න එපා. Read the entire thing after delivery of the placenta is wrong. Right? Understand? So you will have questions like this because the exam anxiety will make you will try to finish the exam quickly. Exam එකේ හම්බෙන anxiety එකට ඔයාව push කරනවා one by one questions ඉක්මනට ඉවර කරන්න. Don't trap to that. Right? We'll train ourselves so you can have time, think about the question and answer. Okay? Good? Are you happy with the question and the answer? All good, everyone? Okay? Oh, Kisima, nani appa. Just express yourself, please. Otherwise, this is like quite monotonous, right? Shall I start asking questions then? Okay, let's move to the next question. Right. Amniotomy, the monkey artificial rupture of membrane, is delayed in breech presentation. True or false? What is the problem with amniotomy in breech? What is the difference between cephalic and breech? Head එක කියන්නේ මොකක්ද? Head is like it's a proper solid structure, right? Circle එකන්නේ. And naturally mechanism එක හැදිලා තියෙන්නේ to deliver cephalic. Cephalic බබාලා හම්බෙන්නේ. At term, breech presentation is about 4%. Okay. So majority of naturally එක හැදිලා තියෙන්නේ cephalic delivery. So when the head is engaged properly to the pelvic inlet, nothing can come out of that. මං කියන තේරෙනවද? Head එක pelvic inlet එකට set වුණාට පස්සේ nothing will come out. But if the breech comes, what do you know about the breech? When you touch your bum, you know that's breech, right? Passing බවයන එකනේ. Is it regular or irregular structure? Irregular, right? So you have clefts in between and then you have back and then you have bumps. එතකොට ඒක engage වුණාට not like the head. There is no solidity in it. So what can come through? මේ මොකක්ද දෙන්න බුල අස්සේ? ARM කරපු ගමන්. rupture කරපු ගමන්. Cord. umbilical cord එකනේ. එන්න risk එකක් තියෙනවනේ. Am I right? Yeah, I'm right. Believe me, right? So breech presentation is one of the reasons for cord prolapse. You know that. There are reasons for cord prolapse. We'll talk one by one. Like abnormal presentation is a reason for cord prolapse. ඒක අහලා තියෙනවද? Now read cord prolapse now. Now I'm opening up your like kind of few windows for you to go back, read and grab knowledge and come back and try. Okay? All right. And then, by the way, when you get purchase the coming sessions, you can access them anytime. You know that, right? Sudhir will and these two coordinators will get it sorted for you. So you can do a session, come back, read the things that you got like that you were not familiar with, and go back and do the same MCQs again and again. Okay? Clear? Right. Okay. So definitely in early breech, when the breech is not engaged, you never do amniotomy. If you do amniotomy, because of these gaps, not like head, because of the gaps, because of this irregularity, the cord can come through. Okay? Clear? So to prevent cord prolapse, we don't do. So it is delayed, that is true. Is immediately proceeded by sweeping the membranes. What is sweeping the membranes? That is a way of induction of labor. Harada? Mechanical stimulation, you sweep the membranes. You do it when the patient is in antenatal ward. Patient enava, induction of labor. You sweep the membranes, keep the patient. Following day also, probably you sweep the membranes, keep the patient. At some point, because of this sweeping, prostaglandin will secrete. Patient will go into, mother will go into labor. Right? You never immediately do amniotomy. It can happen when you do the sweeping. It can happen accidentally when you do the sweeping of the membrane, but you never do membrane rupture soon after sweeping. Do you understand me? You sweep, keep the patient, and then in labor, if you want to start oxytocin, if you want to check fetal well-being by doing amniotomy, you can do it, but not immediately after sweeping. Right? That's false. It's more efficient if the hindwater sac is ruptured. ඔහොම එකක් එකපාරම දැක්ක ගමන් බය හිතනවා මේ මොකද අහලා තියෙන්නේ කියලා. Hind water and fore water කියන දන්නවද ඔයගොල්ලෝ? When the baby is there, fore water is the lico in front of the head. Right? So we rupture the fore water. ARM කරනවා කියලා අපි rupture කරන්නේ fore water. Hind water is the water behind the fetal head, baby's head. Right? That is the water around the baby's body. Okay? It's called කියන්නේ forehead here, right? Foreseen ඉස්සරහා පේනවා. හරි? ඒ වගේ fore water ඉස්සරහා තියෙන වතුර. Hind water is, we can't see hind water. That is behind baby's body. Understand? මං කියලා තේරෙනවනේ? Right. So hind water ruptures can happen spontaneously. So hind water rupture and fore water rupture, two different things. So there is nothing called in කොහෙවත් පොතක නැහැ, there is more efficient if the hind water is ruptured. එහෙම එකක් නැහැ. Clear? එතකොට ඕගොල්ලෝ ප්‍රශ්නවලදී in exam questions also you will get stems like this. So these stems, especially in multiple choice questions. Multiple choice question මේ වගේ වෙනවා. මේ වගේ එකකින්ද ඔයා ජීවිතේට පොතක කියවලා අහලා නැති දෙයක් නම් it is wrong. It is false. If you have not read enough, that's a different story. But if you have read the book, if you understand the concept, something totally unrelated to concept can come like this. So you have two options. If you are quite sure, I've very well read the induction of labor, there is nothing I have found like this, go false for it. Or else, if you think that I'm not sure, this could be a possibility, what are you going to do? Leave it. Sorry? Negative marks in MCQs. If you're wrong, you get negative marks. If you think that you're not sure about it, leave it. If you know that you read this chapter, you are very thorough with the labor, no, there was nothing like this I have read. Okay, go ahead, go false. Okay? Clear? Understand? Harine? I'm telling tricks, right? These are tricks. This is how you score. Okay? Am I clear to you so far? Now I'm dragging this because I'm not getting feedbacks. Please, guys, talk. Okay? Right. Is performed in normal labor at the cervical dilation of 5 centimeters. Is it true or false? Again, a very good stem. It's performed in normal labor. මොකද්ද මෙතන තියෙන වැදගත්ම වචනේ? Noble labor. Clear? Normal labor, you don't have to do anything. That's a physiological process. If someone comes with a spontaneous labor, contractions are there. Are you going to rupture membranes? Are you going to intervene? No, you don't have to. So if there is says normal labor, you don't do anything. You leave it. So this is wrong. And is performed in the antenatal ward. This is a sterile procedure. Are you going to do it in the antenatal ward and ask the patient to walk to the labor room? No. You do it at the labor room. Now, this is something that we check whether you know how things happen, whether you were worked at wards. Because, being medical students, you have to go and see artificial ruptures of membranes, right? The way they do. Have you seen? Some of you may have, some of may not. Don't worry, that's fine. That's okay. That's completely fine. So this is usually we do around 6 a.m. Mage ward dege ude hayata mangkaran. Mage house offices la karanne. So in the morning around 6 o'clock we do, right? So the thing is when we do it, artificial rupture of membrane, because during the morning time we have to get the labor process going on, right? So we get the mothers, ask them to pass urine, come to the labor ward, get them to the labor room beds, clean them, and do one by one artificial rupture of membranes. Okay? So it never done at the antenatal ward. Antenatal ward cord will prolapse. Do you understand? So this is an easy step. Now this term is all about your understanding about normal labor. Normal labor කියන එක මතක තියාගන්න. දැන් මේවා තමයි වැදගත්. Now likewise if you do like maybe labor related 50 questions, you will get to know everything. Then normal labor කියන එක අද ඔයගොල්ලෝ ඉගෙන ගත්තා. Normal labor කියන එක natural process. හරි? You don't do anything. Cannula එකක්වත් දාන්න ඕනේ normal labor එකේ. Do you want to start Sinto? No. Do you want to break members? No. She is spontaneously contracting. Subhava dharmයට අනුකූලව she is delivering. That's all. හරිද? Clear? So, is delayed කියන එක true? Immediately proceed. False. Efficient. In the hind ward, there is nothing like that. That's false. Performed in the normal labor. Normal labor not perform කරන්න false. Perform in the antenatal ward. False. Okay? Right. Another thing. In the exam, usually we don't give 5 false questions. එහෙම දෙන්නේ නැහනේ. උත්තරයක් ප්‍රශ්නයක් අහලා උත්තර පහම වැරදියට ප්‍රශ්නයක් නෙවෙයිනේ. We never will give you like, if you think all 5 are wrong, then you are wrong. Okay, usually we don't give, usually නෙවෙයි කවදාවත් දෙන්නේ නැහැ. එක උත්තරයක් හරි හරි එකක් තියෙන නැත්තම්. Question එකට validity, we give a validity to question. So there is no validity to that question. So these questions, now what the exams should be international standards. You are going to get MBBS, right? So that international standards should be there. So international standards will MCQ එකක් තියෙනවා. You never give a question 5 උත්තර පහක් වැරදි question එකක් දෙන්නේ නැහැ. But there can be questions, all 5 answers can be correct. එහෙම තියෙන්න දෙන්න පුළුවන් ඈ. මේවා basically principles in MCQs. Okay? Understand? Clear? Right. Which of the following are contraindications for epidural analgesia in labor? Right. What now, what I want to tell is, labor is not only delivering a baby. So you will be questioned about some sort of like pain relief, anesthesia related questions. Now this is something related to anesthesia, right? Epidural analgesia දන්නවනේ epidural එක. අහලා තියෙනවනේ pain relief එක දෙනවා කියලා. Yeah. Following are contraindicated epidural analgesia in labor. What are the situations that you cannot give epidural? If the patient is struggling, can you put epidural needle? Patient උඩ පැන පැන නටනවා නම් දඟලනවා නම් psychotic නම් psychiatric condition එකක් තියෙනවා නම් දැන් ඉන්න මිනිස්සුන්ට ගහන්න හදනවා නම් මේ epidural දාන්න බෑ. You cannot do anything, right? To apply, to insert epidural needle, patient has to be still silent. Still ඉන්න ඕනේ බොහොම silent. And follow the instruction of the anesthetist. Head එක bend කරලා දන්නවනේ දැකලා තියෙනවනේ anesthesia දෙනවා. Spinal anesthesia. Have you seen spinal anesthesia? Similarly, epidural is something similar to that. Right? So patient has to be steady and sitting. Right? So there are situations that you cannot give. And what are the other contraindications, especially in epidural analgesia? Epidural kiyanne, you are reaching the epidural space. After epidural space, what do you have? Dewar එකෙන් ඇතුලේ මොකක්ද තියෙන්නේ? Subarachnoid space. Right? Anatomy, eh? Dewar meter, arachnoid meter, pia meter. ඉස්සර නම් එහෙමයි තියෙන්නේ. තාමත් එහෙම තියෙන්නේ. Okay? So, epidural space kiyanne, you go through the dura, right? So you go through the dura and then you get the arachnoid space and then you have the pia meter. So to the arachnoid space, if you go, it's spinal anesthesia. Hurry? Because CSF is in the arachnoid space, subarachnoid space, right? But outer dura, you give dural anesthesia. Epidural can epi means outer side of the dura, right? That is to block the nerve roots, not the entire spinal cord. Understand? Right. So I'm giving now a bit of tinge of knowledge to you regarding anesthesia. So these questions can come. Right. So in epidural anesthesia, you pierce the epidural space. Right? Epidural space. But this needle inadvertently can go into the spine. යන්න පුළුවන් නේ. Pinch වෙන්න පුළුවන්. එතකොට again you are in the spinal. So if the patient is having local area of sepsis, infection එකක් හරි නැත්නම් body sepsis එකක් හරි තිබ්බොත්, are you going to introduce that to the brain? No. Right. Number 2. So number 1 මං කිව්වා patient should be still. Number 2, patient should be not be septic. Number 3, if the patient is having coagulation disorder, මොකක් හරි condition එකක් හින්දා, if there is a coagulation disorder of the patient, platelet dysfunction, low platelet, PTINR is deranged, liver derangement, ඔය මොකක් හරි තිබ්බොත් what will happen? The patient will not produce adequate amount of clotting factors. එතකොට epidural space එකේ hematoma එකක් આવොත් මොකද වෙන්නේ? It will compress what? Spinal cord. Understand? If it compress spinal cord, what will happen? This patient will become paraplegic. Spinal cord compress it, මැරෙනවා. Spinal cord like below that, you get paraplegia. So those are the 3 main conditions. If the patient is suspecting or known to have a coagulation issue, if the patient is having sepsis, or if the patient is not ready and not willing enough, not fix enough to have a spinal. Right. Now we'll go back to the question. ඕක තමයි MCQ කරන එක විදිහක්. උත්තර ටික බලන්න. You close the answers. Now did we go through the question answers? No. This is one of the ways that I do MCQs. You read the question and recall which are the following are okay. Epidural වලට contraindications මොනවද? These are the 3 main rings and then I read. Then you are not biased. Do you understand? Answer bias එක වට එන්නේ නැහැ එතකොට. Do you get the point? I'm training you in a different ways to tackle questions. Different questions. Now, when you see this stem, if you read properly, if you understand your anesthesia and stuff, you know these are the 3 contraindications for main indications for epidural. Okay, now let's go to answers. Eclampsia. What is eclampsia? Eclampsia again? Fitting, ne? You know eclampsia, right? When the patient is fitting. The obstetric eclampsia, eclampsia is hypertensive emergency causing fits. Pre-eclampsia again, about to fit. Derangement is there. Treat කරන්න නැතුව හිටියොත් fit වෙනවා. අපි මොනවද දෙන්නේ ඒකට? What do we give if the patient is severe pre-eclampsia or in eclampsia? What is the drug we use? Magnesium sulfate. දන්නවනේ? ඉතින් මම ප්‍රශ්න අහලා මම උත්තර කියනවා. Please talk. Come on. Right. This is starting, okay? I'm not going to do this forever. You have to talk. Right, HELP syndrome. HELP syndrome කියන්නේ මොකද්ද? HELP කියන්නේ HE means what is HELP syndrome? Hemolysis, elevated liver enzymes, low platelet. හරිනේ? Are you going to give epidural? fit එකේ ඉන්න patient කෙනෙකුට fit එක කියන්නේ මේ අගේ බුදු fit එකක් නෙමෙයි. patient fitting නම් if the patient is fitting you can't give epidural, right? ගැහෙනකොට බෑනේ. එහෙනම් anesthetist also should have fits synchronized. Otherwise you can't give. And HELP syndrome you cannot give because you can have low platelet. Okay? Obstetric cholestasis. What is cholestasis? It's a liver derangement, right? Hare? I told now liver derangement, possibility of coagulation disorder. Right? Coagulation factors are done basics. So can you give epidural? No. Primary dysfunctional labor. What is primary dysfunctional labor? Labor process is slow. It's slowly progressing. Right? So patient in lot of pain for a lot of time and exhausting. Can you give epidural? Yes, this is one of the indications to give epidural. Okay? So you give epidural, you can break membranes, you can do ARM, you can start Synto, you can give more time because patient is pain-free. Right? Primary dysfunctional labor can be augmented. Augmentation කියන්නේ දන්නවනේ. Induction is starting of labor. Augmentation is increasing the progress of labor. So primary dysfunctional labor කියන්නේ labor is flat. Heavy යනවා පැය ගාණක් යනවා. It's not progressing. 4 centimeters to 5 centimeters වෙනවා පැය දෙකකින්. පැය 3ක් යනවා 7 centimeters, 6 centimeters වෙන්න. Slow. We expect usually after 4 centimeters, what is the progress that we expect in a primary? Or multi even? 1 centimeter per hour. Okay? So if it's slower than that, we call it primary dysfunctional labor. Right? එතකොට ඔක වැඩි කරන්න නම් සින්ට දාන්න. සින්ට දාන්න අම්මා exhaust වෙන්නේ නැති වෙන්න we can start oxytocin. Okay? Are we good? Am I confusing you all? Are you all right with my way of teaching? Do you understand? ඔය ප්‍රශ්න තුන තමයි මට තියෙන්නේ. If you want me to change the pattern of teaching or if you want more like a different way of teaching or please let me know. I'm always ready to like mold myself. Right? මොනවාරි තියෙනවා නම් ඔයාලට තේරෙන්නේ නැත්නම් හරි හදා වෙනස් කරන්න ඕන විදිහක් තියෙනවා කියන්න. Right, sepsis. Can you give epidural? Can you? දැන් කියලාත් ඒකටවත් නැහැ කියන්නකො අප්පා. No. Right? Okay. Right. Now see, without seeing the stems, if you know the principle, recall the principle, get into your like the forebrain and start applying, then read the answers. එහෙම කරද්දි මාර ලේසි. ගහගෙන යතේ. So eclampsia false, HELP false, obstetric cholestasis false, primary dysfunctional labor true, sepsis false. Clear? Right. So explanation is here that you can read the entire explanation I gave you. Mama samahara questions waladi, most of the questions when we are discussing in future, I will put explanations. Okay? Explanation for most of them, especially the things that you are not much familiar with. The epidural කෙනෙකුට ඕගලන්ට අලුත් වගේනේ. Yeah. So now you can go through and read this and get the information that I taught. Right. Obstructed labor causes uterine rupture in second para. What is obstructed labor? Contractions are there, but labor is not progressing anymore. So it's obstruct. What are the causes for obstruction? Malpresentation, cephalopelvic disproportion. pelvis එකයි head එකයි set නැහැ. set නැහැ කියන්නේ හරියට process එක නැහැ. One of the main cause is malpresentation, right? So can they cause uterine rupture? Now make a concept එකක්. Natural concept එකක්. In primaries, usually in primaries, the uterus is දැන් මේ labor එක primary කෙනෙකුට මොකක්ද වෙන්නේ? අලුත් දෙයක්නේ. primary කෙනෙකුට labor process එක අලුත්. uterine contractions එනවා අලුත්. the uterus එක behave like a different way. ඒක obstruct වෙච්ච ගමන් uterus එක shut down වෙනවා. uterus will go into atonic, contracting නැහැ. primaries. But multis, they have trained uterus. They have delivered one baby already. Understand? So their uterus, even though it is obstructed, they naturally tend to contract. Contractability කියන එක primaries ලට වඩා multis ලගේ වැඩි. Multis contractability more, primaries less. That is the reason when we use syntocinon, oxytocin, we use higher dose of oxytocin in labor for primaries, lower dose of oxytocin in labors for multis. අහලා තියෙනවද ඒක? අහන්න අද ඉගෙන ගන්න. For primaries, when we start induction and augmentation with oxytocin, we use higher dose. We'll talk about doses later. I don't want to bombard in your head, right? And for multis, we use lower dose. The reason is their uterus is more sensitive to oxytocin because they have gone through the labor process once ago. හරිද? එකපාරක් ගිහිල්ලා දිනන labor process එකේ. So oxytocin receptors are nicely formed and ready to go in multis. So you need a small dose. Understand? මං කියන දේ නේද? Clear? So because of that, primaries, if they go into process of labor, if it's obstructed, the uterus stop. But multis will keep on contract. What happens? මොකක් හරි හිර වෙලා තියෙද්දි, if the keep on contracting, what can happen? Can it rupture? Yes. So cause uterine rupture in a second para. True. Second para කියන්නේ දෙවෙනි පවානේ. ඒක දන්නවනේ. Right. Is treated by application of obstetric forceps in second stage. We apply forceps for obstructed labor. The obstructed na hira velane. Obstructed means it's blocked. If it is blocked, are you going to deliver this baby by applying forceps? No, you are not trying to take the baby from down. You go for a cesarean section. Okay. If it is obstructed, the term obstruction is there. Obstructed labor principle, you never go further influence for vaginal delivery. Okay. Understand? Clear? Okay. Is caused by formation of the Bandel string. Bandel string there's a ring formation happens because upper segment continues to contract. Because of that, upper segment get thicker, right? Lower segment continuously get thin, and then it can rupture. Before rupture, there's a thing called Bandel string which happens. දැන් බලන්න ඕනේ මේ ප්‍රශ්නේ තියෙන English. The important fact is English. Obstructed labor is caused by formation of Bandel ring is wrong. A clinical feature of obstructed labor is Bandel ring is true. Understand? Bandel string එක හැදෙන හින්දා obstructed labor වෙන්නේ. Because of the obstructed labor, you forms Bandel ring. Clear? Understand? ඒතර Bandel string දැක්ක ගමන් මේකට හරි ගහන්න ළමයා අපරාධි ලකුණක් නැති කරගන්නවා. So reading of this stem and understanding the stem is very important. Do you understand? Clear? Any question? Are we good? Are you all understanding me? So it's a clinical feature. Bandel string formation is a clinical feature. But Bandel string doesn't cause obstruction. Because of the obstruction, it causes Bandel ring. Hi? Harinil? Okay? It's all right. It's all right to get confused today. You should get confused today. Absolutely, you should get confused today. Or understand make a gravity. And you should understand the gravity. Then only you will motivate for this, right? Otherwise, if I go just for like very basic questions, that won't do much. You'll be happy, I'll be happy at the end of the day, but at the exam, you'll be not happy. I'm not doing a proper job. Understand? So I'm going to introduce you new concepts in labor and everything. Then මේවා කියවන්න ඕනේ. The other බලන්න ඕනේ internet එකේ ගහලා what is bundling. See a picture, you'll remember forever. We'll do MCQs in future. Today I'm doing very slow because we do only 12 questions. But in coming MCQs, we have to do like 25 questions per day at least. Okay? Right? So we have to be quicker. අපි එහෙම වෙනකොට අපි අපේ ස්පීඩ් එක හදාගමු. Right? Okay. Is treated by upper segment cesarean section in the first stage of labor. First stage of labor කියන හරිනේ. In the first stage obstruction happen. Second stage කියන්නේ fully dilated නේ. එතකොටත් obstruct වෙන්න පුළුවන්. But first stage at 7-6 centimeters you can have obstruction. If the mid pelvis is not enough, head can stuck. Right? Do you do upper segment cesarean section? Why do you do? We never do upper segment. Nowadays we only do upper segment cesarean sections in invasive placental disease. Placenta accreta කියලා කහලා තියෙනවනේ. Accreta percreta, placenta is growing up. එතකොට අපි placenta එක හරහා කපන්නේ නැහැ. Placenta is sitting down. So we go up. So other than placenta accreta spectrum conditions, nowadays we never do upper segment cesarean sections, which is very risky for the patient. Bleeding is high, you have to do a midline laparotomy. And risk of PPH is very high because of that. So we do lower segment. Is caused by occipito-posterior position in women with android pelvis. What is android pelvis? Male type of a pelvis, right? Android can android. Again, male pattern again. No? Are we good? Androgens can work. Male hormones. So android pelvis එකක් තියෙන කට්ටියගේ is it favorable for labor? No. Male pelvis is not favorable for labor. That's why they get obstruction. So occipito-posterior position, is it favorable for labor? No. Occipito-anterior position is favorable for labor. So occipito-posterior තිබිලා android pelvis එකක් තිබ්බොත් බඩුම තමයි. You get obstruction, right? So obstructed labor is caused by an occipito position and women with android pelvis, true. They come out unfavorable. What do you call it? Cephalopelvic disproportion. Pelvis එකත් case, position එකත් case. Okay? Right. So you try and rupture in second para, true. You never apply instruments for obstructed labor, false. Formation of bundle ring is caused by formation is false, but obstructed labor can cause bundle ring, true. Is treated by upper segment cesarean section, false, because we know not nowadays we don't do upper segments. Caused by occipito-posterior position, true. Caused by android pelvis, true. Hare? Clear? Right. Now we'll go for the SBA. But 20 all now SBA think the SBS will come like this. We have a bigger stem. Bigger stem or a statement or a clinical scenario. Based on that, you will have answers. But 20 all prime mother. Anika SBS most important thing, when you do SBS, you highlight. You highlight. Now here, 28 years old, important. She is young and healthy. Primary, first pregnancy, important. Severe pain at episiotomy site. Now, episiotomy is episiotomy. Do you know episiotomy? When the head is pushing, crowning, crowning at the vagina, at the vaginal orifice, introitus, if you think the space is not enough, if you think this can cause a tear for the anus, you go for a incision, a cut, right? Which is called episiotomy, right? 2 hours after vaginal delivery. Then baba deliver karla episiotomy ka dila, somebody probably have sutured it, right? Because being house officers, this question is very important. ඔයා බලන්න ඕනේ මේ ප්‍රශ්නේ මගෙන් අහන්නේ කියලා. Because you are the house officer. You are the one from the very first day going to suture these episiotomies. Right? බය වෙන්න බෑ. පළවෙනි දවසේ ඉඳලා බහන්න එනවා. ගෞරවයෙන් බුදුසරණනේ. So on examination I cannot see. Sorry. There was mild pallor, BP 110 by 60, pulse rate 100, which is normal. Pulse rate after delivery can have 100. 100 can vary, but somewhere there 110 by 60 normal. A large hematoma was present at the episiotomy site. Large කියන වචනේ ඉතාම වැදගත්. It's a large hematoma. If it's a small hematoma, the story is different. What is the most appropriate management? Administration of pethidine. She is in pain. Now, this is what is the next step, not the next step of management. They are asking what is the appropriate management. Appropriate management කියන්නේ ideal management for the patient. උදාහරණයක් විදිහට PPH එක question කරලා තිබ්බොත් PPH එක what is the next step of management? If it says IV cannula, that is the ideal one. Okay? Patient is talking and airway breathing is all right. Circulation, next step is getting the cannula in. So that is the next step. But what is the appropriate step? උත්තරයක් තිබ්බොත් PPH එකක් ඒටොනික් කියලා. Start uterotonic drugs. හරි? ඒක තමයි appropriate. Cannula එකක් දාලා බලන් ඉඳලා හරියන්නේ නැහැ. Next step cannula, appropriate step is the ideal management. Here they are asking appropriate management. Pethidine දීලා හරියනවද මේකට? What is pethidine? A pain relief. Are you going to give pethidine for this patient? Yes or no? She is in pain. See? Severe pain. Do you want to pain relieve her or not? Pause it there. Don't you want to give her pain relief? No. Yes or no? If someone is in pain, do you want to give pain relief or not? Do you want to give pain? Exactly. You have to give pain relief, right? So you can give pethidine. That is probably the next step, not the ideal step. That will not cure her. Tranexamic acid. What is tranexamic acid? Antifibrinolytic. Right? What is the action? It forms a clot. Fibrin cadilian, fibrin remains. Right? So it forms a clot. Are you going to administer tranexamic for her? Can give. Obviously, I would give. Bleeding you can give. But is that the appropriate thing? Large hematoma, no. Allow to resolve spontaneously. If it's a small hematoma, give tranexamic, give pethidine, allow to spontaneous. Allow to spontaneous. Can I pay the Katunakim Balano? Look in Nata? Hurry. Put hematoma. Right. So the word large is very important. That's why I ask you to highlight. Right? Exploration of the hematoma. That is the answer. You explore it, find the bleeder, tie it, again resuture it. Okay? Tight vaginal packing. The people who don't know what is episiotomy will say this. Vaginal packing karanne internal tears, internal cervical tears and oozing. එතකොට තමයි vagina එක pack කරන්නේ. This is out like introitus, right? Introitus එක pack කරන්න බෑ. Can you pack introitus? Is the edge? You cannot. The hematoma is lateral pelvic wall or lateral vaginal wall hematoma. Yes, you can do packing to prevent further bleeding, to give tamponade. But outer thing, you cannot give tamponade. Get it? To you? Cool. Good. Right. The next one. 30-year-old woman in her second pregnancy presented in spontaneous onset of labor at 39 weeks of gestation. Her cervix is fully dilated and vertex is 2 centimeters down. Okay? +2. Ischial spines, you know how to assess the station, right? You do a vaginal examination at the level of ischial spines. How much above? How much below? If it's below, +1, +2, +3, that the verge of vagina, minus upper, right? Cervix is below, vertex 2 centimeters below the ischial spines. Her first pregnancy is complicated with shoulder dystocia and was managed successfully. What is the next step in management? Next, here see, මම මේ ප්‍රශ්න දෙක දැම්මේ එකයි. Most appropriate here next step. 30-year-old woman, second pregnancy, spontaneous labor, 39 weeks, cervix fully vertex +2. ඔයා history බලනකොට ඔයා දන්නවා අම්මට සිරි කලින් සැරේ shoulder dystocia එකක් වෙලා. What are you going to do now? Are you going to anticipate shoulder dystocia in this patient? Are you going to anticipate shoulder dystocia? And why do you anticipate? Because shoulder dystocia, you cannot be hanky-panky. විනාඩි 5ක් ඇතුළත බබා ඩිලිවර් කරන්න ඕනේ නැත්නම් බබා මැරෙනවා. Baby's head is out. Thorax is inside the vagina. Tightly applied. හරිනේ? ඒ කියන්නේ shoulder dystocia කියන්නේ. හරිනේ? thorax එක තියෙන බබාගේ pelvis එකේ අම්මගේ head එක එළියේ. What happens? Baby start breathing. Thorax can't expand. So huge negative pressure එකක් build වෙනවා. The baby cannot breathe and can die because of hypoxia. Do you understand? Clear? ඒක තමයි shoulder dystocia. Shoulder dystocia එක manage කරන්න the person should be then and there. So none of the shoulder dystocia can be like left ignored. ඔයා anticipate කරනවා නම් if you anticipate a shoulder dystocia, you have to be prepared for it. Believe me, when you are preparing for it, it will not happen. When you are not ready, it will happen. Right? So you are the house officer. I want my house officer would be the safest house officer. Right? That's why I give this question. You know, මට සිරි කලින් සැරේ මෙයාට shoulder dystocia එකක් ඇවිල්ලා. බඩුම තමා. What am I going to do? I have to be prepared. What do you mean by getting prepared? Are you going to do emergency cesarean section? No. මේ anticipate කරා කියලා බඩ කපන්න ඕනේ නෑනේ. Right. Inform a senior person. Yes. Bring down a skilled person. Your senior house officer or the consultant. So that person will be there when that head comes out. Are you going to get him when you put the patient to labor room? Labor room එකට දාලා බැනුම් අහන්නේ. අර මිනිස්සුන්ට අහිංසක මිනිස්සු ඇවිල්ලා ඉන්න බෑ. Right? At the +2 fully dilated, you get the patient down. Sorry, person down. The senior person. Okay? Right. Instrumental delivery. Are you going to go do an instrumental delivery with this patient? No need. This patient is fully dilated. She will deliver at some point. Perform episiotomy. No. Are you going to perform prematurely? Episiotomy කියන එක දෙන්නේ crowning. Crowning කියන්නේ. Do you know what crowning is, right? The widest diameter of the head is coming through the vaginal orifice is crowning. Okay? Then only you give episiotomy. Perform Macrobert's maneuver. Macrobert's maneuver දාන්නේ head එක අවිල්ල shoulder dystocia නංග. නිකන් දාන්න Macroberts. අර මනුස්සයා බල මේ මොකද බබා බඩ ඇතුළේ ඉන්නේ. You know Macroberts, right? You lift the legs up, right? Knees to chest up. උඩට මුස්සන කකුල්. We'll talk about this when it comes to shoulder dystocia. When we are discussing more labor questions, we'll discuss. Okay? So, being a safe house officer, what are you going to do? You get the senior person down. Hurry. So, he will be there at the time of delivery. If we noticed shoulder dystocia, he can quickly act. Good? Are we clear? Okay. So, that's about labor. Few questions. Gynecological malignancies from, right? I'm just showing how gynecology part will be out of obstetrics. What do you want to say? All right. First question. Ultrasound scan. USS කියන්නේ එක. Ultrasound scan features of a malignant ovarian tumor. Malignant ඕනම cancer දෙයක මොනවද pathology වලට ඔයගොල්ලෝ ඉගෙන ගත්තේ? They are not smooth. Are cancers? No, they are not smooth. They can be like solid. Cells හැදෙනවනේ. Proliferate, right? These solid things can secrete fluid, though there can be cystic areas as well. What happens in the cancer cell? Cancer එක grow වෙනකොට මොකද වෙන්නේ? Are they hypervascular? Vascularity වැඩිද අඩුයිද? Blood supply. High. They are hypervascular. Right? Are they uniform? No. Why? Necrotic areas are there because growth is more extensive than the requirement of nutrition and oxygen. Blood supply එකට වඩා වැඩිපුර grow වෙන්න හදනවා. Cancer නේ. So the necrose. So will it be isoecogenic or multiple ecogenicities? Multiple ecogenicities. දැන් මම ඔයගොල්ලන්ට උගන්වන්නේ gynecology obstetrics නෙමෙයි. This is pathology and understanding about cancer. See the way they question you in the final exam, right? Will they go bigger, faster or slow? Bigger, faster? They are not slow. Fast growing. Can malignancies deposit various other places? Metastasize. So in the abdominal cavity, if there is metastasis, what will happen? Do you know ascites? We can cause it ascites. So malignant features, M features ke M features and B features of, right? M features are solid areas, hypervascularity, ascites, papillary projections, presence of papillary projections, and features of distance metastasis. Right? ඕක දැනගෙන මේ ඔය ටික හිතලා you go and see the question. Right? Smooth cystic tumor. Smooth කියපුවම හරි වෙයිද? වැරදි. Cystic cyst විතරක් තියෙද? Cystic tumor. නෑනේ solid areas තියෙන්න ඕන. Diameter larger than 10. Diameter larger than 10 possible, but it cannot be a smooth cystic tumor. If a malignant tumor is 10 centimeter large, that should definitely have what? Solid areas. මං කියන තේරෙනවද? ලොකුණ පළියට කැන්සර් වෙන්නේ නැහැ. ලොකු ටියුමර්ස් තියෙනවා benign fluid පිරිච්ච ඒවා. serous cyst adenoma, mucinous cyst adenoma. අහලා තියෙනවද? Those names. They can go bigger. සමහර ඒවා බඩෙන් එකයි. pregnant වගේ අම්මලා සමහර patients. You can come like, 20-30 centimeter of tumors, but nothing inside. So they are benign. Okay? Ascites, is it a malignant feature? Yes. Increased vascularity? Yes. See, easy. ඕක තව විදිහකට අහන්න පුළුවන් කියලා කරන්න. High Doppler flow. Ultrasound වචන වලින්. True or false? True. Presence of at least one papillary structure. True or false? True. At least one. එකක්වත් තියෙන්න ඕන. Papillary structures are growths. Surface එකෙන් grow වෙනවනේ. Understand? Solid area, papillary projections, ascites, high vascularity, distal mets. ඔය ටික නේ septations, present of septations කියන එක malignant feature එකක්ද නැද්ද? මතක තියාගන්න නෑ. Just presence of septations are not malignant features. Just presence of septations කියන්නේ M feature එකක් නෙවෙයි. හරිද? Right. At least one papillary projection, yes, but the papillary projection should be more than 4 millimeters. අහලා තියෙනවනේ? M features. බලන්න අද කියලා බලන්න. Right. Presence of solid areas. True or false? True or false? True. හරිනේ? Are we clear? Do you have doubts? නෑනේ. දැන් මම මෙතනට ආවේ M features උයි B features උයි කඩපාඩම් කරලාද? නෑ. මම ඉස්සල්ලාම ඕගොල්ලන්ට මොනවද කිව්වේ? features of a malignancy. මොලේ වුණත් malignant එකක් නම් මේ විදිහේ තමයි. blood supply වැඩි වෙනවා. metastasize කරනවා ළඟ පාතට. And then necrotic areas තියෙනවා. solid areas හැදෙනවා. ඔය ටිකනේ. Out of that you have wherever it is, these are the features. Okay? So always logically think and put into your brain. So I will not forget. Right? හරිද ළමයි? Okay. Are we good? Understanding? Good. Right. Risk factors for cervical carcinoma include. Right. Tell me what are the risk factors for cervical carcinoma? High parity. Parity එක වැඩි වුණා කියලා එහෙම එකක් වෙන්නේ නැහැ. Right? Infection with human papilloma virus type 20. Type 20 කියලා මම දැන් ඔයගොල්ලෝ අහලා තියෙනව නෑනේ 16, 18, 30 1 and 36 35 or 36 ඔය ටිකනේ තියෙන්නේ common ඒවා high risk low risk HPV ඕන තරක තියෙන්න පුළුවන්. ඒතර අහලා නැති එකක් කොහොම තිබ්බොත් එක්ක අතාරින්න නැත්නම් false. Clear? Understand? Smoking. True or false? True or false? Smoking. True. Why? What is human papilloma virus and how this can cause cervical cancer? Now, api hamoma, being young, we all get infected with human papilloma virus. Don't worry. Right? When from the beginning of your coitus, like why do you call it koitake? Koitake can haldi the first coitus. From the beginning of the first coitus, you, me, and everybody are vulnerable for human papilloma virus, right? Human papilloma virus vulnerability is increased with multiple sexual partners. ඒක අහලා තියෙනවනේ. එතකොට වැඩි. එතකොට මෙතන ඒ risk factor එක දාලා නැහැ. දැන් මම හිතේ ඒක හරියම ලේසියිනේ. True. Risk factor of the cervical carcinoma include what do you call this? Non-monogamous relationship කියලා තිබ්බොත් හරි. Right? Or multiple sexual partners කියලා තිබ්බොත් හරි. මං කිය තේරෙනවද? Clear? මොකද කාගෙන් හරි HPV එන්න පුළුවන්. එහෙම නැතුව single sexual partner හිටියත් HPV එන්න පුළුවන්. හරි? HPV එනවා යනවා. හරි? Why? Because of the immunity. Young ladies, young girls, especially when they are young, especially in other countries, they get commonly infected with HPV because of multiple sexual partners. But being healthy and young, your immunity is killing them off. හරි? ඒකයි HPV DNA testing කරපුවාම positive එක්කෙනෙක් සති දෙකකින් කරද්දි negative වෙනවා. සති දෙකකින් නෙමෙයි අවුරුද්දකින් කරද්දි negative වෙන්න පුළුවන්. තේරෙනවද? Clear? This can be cleared from the body because of the immunity. හරි? virus කැස්ස හැදෙනවා වගේ තමයි. හැදුනා අයින් කරා. But sometimes it remains. One of the reason for remaining is lack of immunity. Lack of immunity වෙන දේවල් මොනවද? Smoking lack of immunity වෙනවද? Huh? Do you lose your immunity with smoking? හරි. වෙන මොනවටද වෙන්නේ? හරිනේ? ඔයගොල්ලොත් එක්ක ක්ලාස් කරනකොට මට මාවත් ෂුවර් නැතු යනවා. I'm just kidding. Huh? Okay, yeah. Smoking. Smoking reduce immunity. So the chances of infection is more. Remaining infection is more. So chances of getting a cancer is more. Right? Early marriage. True or false? Damn you. Of course, yes. Why? Early koitake. Atrama early marriage, neme early koitake. Before even you get married, you can have sex, right? So early koitake. Hari vachane koitake. First sexual intercourse. Right? Recurrent miscarriages. True or false? Is there something related to that? Have you heard to that? කිසිම ගැළපීමක් නැහැ නේ. Recurrent miscarriages is cervical cancer. ගැළපෙනවද? සම්බන්ධතාවයක් හිතා ගන්න පුළුවන්ද? බෑනේ. හිතා ගන්න බෑනේ. හිතා ගන්න බැරි නම් වැරදිද? If there is nothing, I mean, cervical cancer and recurrent miscarriages, you are not, it's not fitting each other, right? Understand? What else? COCP කියලා තිබ්බොත්. True or false? True. COCP, combined oral contraceptive, increase the risk of cervical cancer because of cervical cellular changes. Glandular structure එකෙන් වැඩි එතකොට ඒගොල්ලෝ infected risk එක වැඩි. හරිද? So high parity? No, false. Infection with immunopapillomavirus 20, which is very, I think it's false. I'll check it further. මට ඒක හරියටම sure නෑ. But 20 කියලා එක අපිට commonly අහන්න නැති හින්දා I think it's false. Smoking true. Early marriage true. Recurrent miscarriage is false. හරිනේ? Related නැති එකක් තිබ්බොත් false, huh? Right. In carcinoma of the ovary, abnormal uterine bleeding is a presenting symptom. True or false? In cervical cancer, abnormal uterine bleeding is a presenting symptoms. True or false? True ne? Bleed වෙනවා කියලා නෙන්නේ. හරිද? Endometrial cancer, abnormal uterine bleeding is a presenting complaint or not? True. Ovarian cancers, abnormal uterine bleeding is a presenting complaint or not? මේ වගේ ප්‍රශ්න මේ උත්තරේ බලන්න ඕනේ no කරලා. no කරලා කියලා කියන්නේ ඔයා question කරන්න ඕනේ abnormal uterine bleeding is not a presenting symptom. Is it true or false? Not a presenting symptoms. Ovarian cancer වල abnormal uterine bleeding එන්න බෑ. හරිද වැරදිද? True or false? බෑමද? එන විදියක් කියන්න. Granulosa cell tumors කියලා අහලා. What is granulosa cell? The cell producing estrogen. Right? So granulosa cell tumors and theca cell tumors කියලා අහලා. Thecoma. They are producing again androgens and estrogens. What happens? These will go and one of the hormone හදන්නේ. Cancers, but the cells are producing hormones. These hormones go and what will cause? Grow the endometrium. Clear? Estrogen grows the estrogen like flourish the endometrium, right? Isn't it? So they abnormally thicken the endometrium. So can they bleed? So if someone is having granulosa cell or theca cell tumors, they bleed. They can bleed. So if you say abnormal uterine bleeding is not a presenting symptom, is it true or false? False. Sometimes it can. Right? Abnormal uterine bleeding is a presenting symptoms. Can you say no? Right. තේරුණාද? ඒ එක විදිහක් MCQ වලට ආන්සර් කරන. දාලා බලන්න නෙගටිව් ලයින් එකට දාලා බලන්න. no කරලා බලන්න හරිද වැරදිද කියලා. no කරපු ගමන් වෙනස් වෙනවා. no කරපු ගමන් abnormal uterine is not a presenting symptom. කවදාවත් වෙන්න බෑ. වැරදි. වෙන්න පුළුවන්. These are the instances. So it is true. Clear? ඒක තේරෙනවද MCQ කරන විදිහ? I'm telling you all these tricks, huh? We'll practice them, but within the introductory course, I want to give you all the tricks. That's why I make all these questions based on, show to you all the tricks that we have, right? Adjuvant radiotherapy is given from stage 1C onwards. Then, okay, මොකක්ද කියන්නේ? Cancers, ප්‍රධාන cancers ජාති තුනයිනේ තියෙන්නේ. Gynecology, cervical cancer, endometrial cancer, and ovarian cancer. Surgical staging දැනගන්න ඕනේ. හරිද? staging ටික ලියලා කොළ ටිකක් බිත්ති අලව ගමු ඈ. ඒ තුනට I can even send you the staging. You can download. There is a called FIGO staging of cancers. They came up in 2019 and 2020 FIGO. 2020 FIGO came up with newer staging system which you can get to you, right? හරිද? staging ටික අලවලා තියලා පාඩම් කරගන්න. ඔක්කොම කටපාඩම් කරන්න ඕනේ. අපි ඒක exam එකේ MCQ වෙන විදිහට අපි will fix ourselves, and whenever we get a staging question, we recall the stagings that we need to know, need to remember. හැම stage එකක්ම ඕනේ නැහැ. මතක තියාගන්න. Adjuvant radiotherapy is given from stage 1C onwards. Wrong. මොකක්ද දන්නවද හේතුව? රේඩියෝതെරපි අපි කිසිම ovarian cancer එකකට දෙන්නේ නැහැ. We are giving chemotherapy. Clear? See? This is the things. දැන් මේක දැක්ක ගමන් ගොඩක් කට්ටිය බය වෙනවා staging මතක නැත්තම්. If you can't remember staging, oh my God, I can't remember whether it's 1C or 2A from starting. But ultimately, what I have asked is a very basic question. Radiotherapy. We are not giving radiotherapy for ovarian cancers. Radiotherapy is confined only to cervical cancers and some endometrial cancers. Clear? හරි නේද? radiotherapy දෙන්නේ නැහැ. A principle එක විතරක් දැනගත්තත් මේ උත්තරේ you can mark the answer, right? Staging is done at laparotomy. True. Ovarian cancer staging is done at laparotomy. It's surgical staging. Cervical cancer මොකද්ද staging? Clinical staging. You do examination under anesthesia, assess the parametrium and everything, and see the local spread. So it's a clinical staging. Endometrial cancer, radiological staging. You do MRI and check the spread of the myometrium, spread to the lymph nodes, and the distance. Clear? ඒක මත තමයි. Ovarian cancers, you cannot do radiological staging properly because deposits can be tiny and deposits can be all over the abdominal cavity where you cannot stage properly. Right? Even in a CT, you may not see the surface growth of ovarian cancer. That's why you open up and describe everything. Staging කොහොමද කරන්නේ ovarian cancer? You open up the abdomen, midline laparotomy, take fluids first. Ascitic fluid ගන්නවා. මොකද ascitic fluid වල cells තිබ්බොත් that upgrade the stage. ascitic fluid තිබ්බ නැත්තම් මොකද කරන්නේ? Peritoneal washings ගන්නවා. You put saline into the tummy and just wash it, කලත්තලා drag it back to see whether there is any cells. Hari? That is called peritoneal washing. And then you check one by one whether the ovary, it is confined to the ovary, whether capsule is breached, the next ovary, pelvic peritoneum, pouch of Douglas, paracolic gutters, diaphragm, surface of the liver, undersurface of the liver, spleen, omentum, mesentery, bowel surface. ඔය ටික ඔක්කොම බලන්න. That is called staging laparotomy. හරිද? මතක තියාගන්න ඕනේ. පුළුවන්. Right? බය වෙලා දින් කිසිම hello හොල්ම නෑ. හරි ලේසි මචං. ලොකු දෙයක් නෑ. දාගන්න පුළුවන්. හරි? And patient present early. Do they present early? Ovarian cancers. නෑනේ. ඇයි නැත්තේ? They are not bleeding. Bleed වෙන පුළුවන් situations තියෙනවා. But endometrial cancer, cervical cancer, they expose, bleed. And cervical cancer, even you can see because you do pap smear. You detect early and you have a precancerous stage in cervical cancer. In ovarian cancer, there is nothing. It's intra-abdominal. And ovarian cancer, what is the commonest symptom? What do you call it? They call Goff symptoms. Dyspeptic symptoms, gastritis, they get gastritis. So most of the times, GPs and people usually treat them for gastritis for long time. So until they develop ascites and distension of the tummy, most of the time they don't come. Usual presentation of the ovarian cancer is beyond stage 2. That is why they are a killer, silent killer, difficult to diagnose. So present early, false. Unilateral salpingo-oophorectomy is performed in stage 2 disease. That is knowing the stage. Stage 2 disease, you have to do complete staging, hysterectomy, bilateral salpingo-oophorectomy. Only stage 1A disease. 1A කියන්නේ එක පැත්තක ovary එකක් විතරයි involved. Understand? Staging. You read the staging. Stage 1A is involvement of unilateral ovaries. Stage 1B is involvement of bilateral ovaries, but capsule is not breached in both. Right? So if you see nothing else than 1A, it is not unilateral salpingo-oophorectomy. Unilateral කියන්නේ එක පැත්තයි. හරිද? Clear? Are we good? Do you understand? Right? දැන් අද තියෙන වැඩ කීපයක් labor mechanism එක staging ඒ ටික ලස්සනට හදලා බිත්ති වල ගහගමු this few weeks let's work together. You will definitely get through. Mark my words. Right? Okay. Explanation is here. You can go through. See, 1A, grade 1 and stage 1B, 1 mucinous tumors are the one who surgery alone. Other need chemotherapy. Radiotherapy is never an option in ovarian cancers. Patients with 1A tumors who wish to future fertility, only we offer unilateral. But then you have to make sure there is no macroscopic disease, there is no ascites, nothing. Okay. Right. Okay. So, a 57-year-old woman complains of right-sided lower abdominal pain for 1 month. She has reached menopause 5 years ago. Ultrasound scan reveal a unilocular thin wall cyst with no solid areas, measuring 7.5 centimeter in diameter in the right ovary. CA125 is 10. What is the next step in the management? Now, this is for you all to get to know what is it? Risk malignancy index kila कहते हैं RMI. We calculate RMI for postmenopausal women, right? For postmenopausal women, usually they don't have endometriosis. Postmenopause ne? එතකොට endometriosis වලින් CA125 වැඩි වෙන්නේ නැහැ. So if the CA125 level is more than 30, postmenopausal women, they don't have endometriosis and stuff like that because they are not having periods. So they have, if there is irritation in the peritoneum, there should be something pathology going on. Usually, if the CA125 levels is more than 30 in postmenopausal women, the risk of malignancy, the percentage of risk of malignancy sensitivity is about 75% and beyond. Risk එක වැඩි 30ට වඩා වැඩි න. So being postmenopausal, if there is a cyst, we have to be very careful. But look at this cyst. It's unilocular, thin walled, no solid areas. Does it look malignant? Does it look malignant? No. It looks benign, right? Right. CA125 is 10. So it's less, right? So risk malignancy is less. But the major factor here is the cyst is 7.5 centimeters. So when there is a 7.5, more than 5 centimeter cyst, we can miss maybe a small solid area. I look in a cyst ultrasound only miss වෙන්න පුළුවන්. But when there is a cyst more than 5 centimeter in a postmenopausal lady, do you want to keep it? No. So even though it looks benign, you have to take it off. If it is less than 5 centimeters, what are you going to do? RMI score is very low, CA125 10. Cyst is no solid areas, thin wall cyst, 4 centimeters. You can follow up. You can do a scan, another scan in 6 months or 3 months. Right? So postmenopausal cyst, කියන එක කියවලා බලන්න. There's a guideline, green top guideline. Right? අහලා දෙනවනේ green top guidelines. RCOG green top guideline, postmenopausal cyst. Type it, it will come. That's based on that guideline, we give you questions. Right? Are you aspirate Orion cysts? No. වැඩක් නැහැ නේ field එක. Perform a repeat ultrasound scan in 4 months. We could have done it if the cyst is less than 5 centimeters. Perform laparoscopic oophorectomy? Yes. Are you going to do cystectomy for her? Are you going to do cystectomy? No. She is menopause. Her ovary is anyway not working. Right? Is it laparoscopy good for her or not? Minimally invasive surgery. Does it look like malignant? No. So, even you can spill. But you don't spill. You take it, do the salpingo-oophorectomy, put it in a bag and take it through the one of the holes. Bags වලින් ගන්න පුළුවන්. Bag එක umbilicus එක ගාවට ඇදලා ඌරකින් bag එක හිල් කරනවා. Bag එක නෙමෙයි, like the cyst. And you suck it when it is inside the bag. And you take it out. මං කියව තේරෙනවද? Oh. So laparoscopy, minimally invasive. Elderly lady, she can get back to her normal routine quickly. Perform total abdominal hysterectomy and bilateral salpingo-oophorectomy. Do you want to do that? That much of extensive surgery for this lady? No. Perform laparoscopic cystectomy. Do you want to do a cystectomy for a postmenopausal lady? No. Easy, ne? If you logically think, it's easy. Easy, right? Okay. A 50-year-old woman who had reached menopause 2 years ago presented with a single episode of postmenopausal bleeding. Now, this is again SPA. Abdominal and vaginal examinations are normal. Transvaginal scan reveals and endometrial thickness of 3 millimeter. The 50-year-old woman who has reached menopause 2 years ago, present with single episode. Now, meva highlight kara 50 years, menopause 2 years, single episode of postmenopausal bleeding, abdominal and vaginal examination normal, no masses, nothing. Transvaginal scan reveals endometrial thickness of 3 millimeter. What is the most appropriate step? Now, this is a principle that I'm going to teach you. What is the principle? Okay, learn again. What is the thickness that you're worried about? 4 millimeters, exactly. Right? Good, good. 4 millimeters. If it is 3, postmenopausal single episode, what are you going to do? Send her home. Yeah, anyway, you have to send her home. Whatever you do. Are you going to follow her up or not? You have to. You send her home, but follow up. Right? Okay. So, what is the most appropriate next step? Perform fractional curettage. No. අපි දැන් curettage කරන්නෙම නැහැනේ. ඒක blind procedure එකක්. Perform hysteroscopy and biopsy. That is the gold standard for anybody who's coming with postmenopausal bleeding, because you can have a focal region. Now, this is the principle. If someone comes with postmenopausal bleeding with a focal lesion, irrespective of the size, you have to do a hysteroscopy and biopsy. If it is a uniform thickness less than 4 millimeters, you can reassure them, send. But if it is first episode of bleeding, if the same patient coming with a second episode of bleeding, less than 4 millimeter, you have to do hysteroscopy and biopsy. Clear? Right. Pupil aspiration? Okay, but pupil aspiration, hysteroscopy is far more superior to pupil aspiration, but not indicated for this patient. Perform total hysterectomy. අනේ අර අහිංසක මිනිස්සයව දාලා hysterectomy කරේ පායම කරන්න. It's false. Relieve 3 months or earlier if bleeding recurs. Which is right. Okay? මේ වගේ question හරිම ලේසි. මොකද පිපෙල් එකයි කියුරේට් එකයි hysteroscopy තුනම තියෙනවා කියන්නේ they all are options for assessment of endometrium. ඉතින් ඔය best answer එක ඔය තුනම වැරදි නම් something else should be there. Do you understand? That is been tricky. ඔතනින් එකක් හරි කියලා හිතන්නේ කොහොමද? Best answer. Ideally, perform hysteroscopy is better if there is a focal lesion. Or if she is presenting with the first episode more than 4 centimeters, 4 millimeters, true. But all three are evaluating techniques. The හිතට එන්න ඕනේ best answer එකක් නම් all three should be wrong. Clear? So something else. Review in 3 months or earlier. Do you understand? Right. So that's about it for the day. We did 12 questions. So at the end of the day, I know you have a lot of queries and questions, even though you don't talk about it. You have a lot of concerns, doubts, and මොනවද අපි කියන්නේ? සිත තැවුල් බවට පත් වෙලා එහෙම ඇති දුකට පත් වෙලා you have to read a lot, you have to recall a lot, you may have to think about, because this is the first step of doing this. We'll do more. But what I want is you all to don't get disheartened. We'll take one step at a time. We'll gradually build up. Now, believe me, for last set of students, when I did the MCQs and OSCEs, they were really, I have seen them growing, especially at the OSCE stations. So most of them, I did a physical, like personal OSCE stations for them, like proper OSCEs in Colombo. So it was a remarkable difference I have seen from the entry of them, the entry time from the exit, right? Because most of you probably have not done proper obstetric examinations, gynecological examinations, instrument identifications. So we can do them when it comes to OSCE, but at this particular point, we have to focus on the MCQ and SPAs. But with time, believe me, with time, when you gradually build up yourself, you will see a difference in you. Then you will start trusting yourself. So that's the trust that I want to grow inside you. So we'll do this gradually. So please keep in touch with me. If you could, I hope this session went well, right? Do you get good information? Are you happy with the way I'm teaching, or do you? Because your feedback is mandatory for me to give you a like better delivery, right? For the better delivery, I need feedback. So please give feedback. If you are reluctant to give me feedback straight away, please feedback our coordinator, Sudhira. So he will let me know, right? And believe me, most of the students who sat for the OSCE, I have this, last OSCE stations will be on 9th. I'm one of the examiners, I'll be there. So most of them performed well as they gave me positive feedbacks. They personally thanked me and gave me positive feedbacks because they got we did actually like a good real time thing going on. So they built themselves. I have seen them growing. So I'm so happy about it. I'm self-satisfied. So believe me, I can fix this. Trust yourself. Number one. Trust the process. Number two. If you read now, today MCQs, after doing this session, if you just ignore, that's it. Don't do that. If you are tired now, it's late night, take a good sleep. Make sure you stay hydrated and sleep. Never ever nidhi maragena kavadaවත් වැඩ කරන්න එපා. You all are maybe different learners, like studying people. I'm a person, I'm a night person. I stay late night, I study late night, and I sleep well until late morning, right? So මොකක් හරි විදිහක් ඕගොල්ලන්ට තියෙන්න ඕන. Some people, they want to sleep early and wake up in the early morning. So 6-hour continuous at a stretch sleep is mandatory. Otherwise, nothing will hit your brain, right? And then in between, naps and gaps are needed, right? You cannot study without proper self-care, good food, and make sure you stay hydrated, because circulation to your brain is most important to keep things remembered. These are some basic things. But I just want to tell you, what happens is we are anxious and we are like we don't know that we are running a race, but we are running a race. You can do it one step at a time. So I hope you have got some insight about how gynecology and obstetric MCQs and SPA would be in the exam. So let's do this. Let's get involved to the future sessions, and we'll be conducting regular sessions, most likely once or twice per week, 25 each, SPAs and MCQs in all the modules, from all the modules. So it will be covered basically by like 200 to 300 MCQs. I'm hoping to cover the entire syllabus, but that doesn't mean that you have your part you have to do. Whenever we do a set of MCQs, if you are clueless about MCQs particularly, prioritize them, read them first. If you have doubts about certain MCQs, read about them, read around, right? And when it comes to staging and stuff like that, you have to remember. So write it, paste it on your in front of your table, right? So let's do some works like that, like some exercises which will definitely help you. All right. Do you have any question? Anybody? Please ask question. Any questions? So you understood everything. Wow. Either you understood it. This is a common thing, right? The lecturer certainly. Either you understood everything or nothing. Are we good? Shall we call it a day then? Okay. All right. All the best, guys. Thank you for joining. And then if you think that it's good to continue like this, get involved, and then tell your friends also. And then let's move forward from here. Okay. All the best. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Right.